coming in, Jack, some very detailed information on the prevalence of aortic stenosis. And I am actually with Alec Vahanian, who wrote the commentary accompanying the Jack article. And Dr. Vahanian is from Bichat Hospital, Paris, France. Okay, let's talk about this, because the prevalence of, at least in general, aortic stenosis, and then we'll talk about the more severe type.
Yes, thank you. Well, aortic stenosis is frequent. How do we know that? We have studied. I think in the US you have the very famous study from Como, the Mayo, and Minnesota. In Europe we had, it was not epidemiological study, it was URAT survey we ran in 2003 all over Europe, and we found that it was the most frequent disease requiring hospitalization. But very recently in European Heart Journal we had a paper coming from Scotland, and they were able to analyze 15,000 patients, elderly patients, and they showed it's number one among the valve disease cause for hospitalization. What is interesting, they compare 1997 to 2005, and they found over 50% increase in the number of hospitalization for aortic stenosis. It's not a dramatic increase due to epidemiology. It probably shows that we are better at diagnosing aortic stenosis, because aortic stenosis in elderly may present as heart failure of unknown cause, and if you do not, like Catherine Otto used to say, listen to the patient, look at the echo, you won't diagnose it and you'll treat heart failure. So I think we should be aware of the very high prevalence. Look at it when you consider doing CABG to a patient, elderly patient. Look at the aortic valve. They may well be moderate to severe AS. I think it's very important to know that. So it's very frequent.
And with an aging population, more and more of us will probably end up with TAVR somewhere along the line.
Yeah, well, TAVR is of course there. What we knew from many studies in the US, and I think once again I would like to quote your art survey we did, it was in 2005, I think, in 2003, the first one, we pointed out that as many as one-third, over 30% of the patients over 75 with symptoms, severe aortic stenosis, were not discussed even with a surgeon. The cardiologist left them at home. And this figure would probably be much higher if you go to the GP office, and even higher if you go to the patient's home. So it was an undertreated disease, has been confirmed in the US, in many, many places now all over the world. Dr. Bach did very nice studies also. Now, the patients were afraid of surgery, cardiologists were afraid. Why? Because we, cardiologists, consider that surgery is risky in this elderly with many comorbidity. But we completely forget that natural history is even worse. These people are going to die. So we have to think more about intervention. And now, for more than 10 years, thanks to Alain Cribier, TAVR is there. And TAVR is very nicely catching up. I don't know, over 100,000, hundreds of centers doing that. And thanks to the partner study, today they are the only randomized trial that we have, but it's very good to have it within 10 years, and the thousands of patients in registry, mostly in Europe, we have data, quite solid data, confirming what we thought, because putting a bioprosthesis in means that it will work. We confirm that it is very effective treatment for valve function, confirm that the risk is there, but not dramatic if you properly select the patient, and midterm outcomes are very encouraging. Now we have many data over 3 years, 5 years, very encouraging, but we don't know the whole story, of course. We have to better manage the complication, etc., etc. It's a very interesting paper, but of course it's a post-hoc microstimulation, etc. And we have to be extremely cautious, because it's difficult to say post-hoc, when looking at data of thousands of patients, if this patient is a candidate or not for TAVR. And Michael Mack, US surgeon, friend, very nice guy, used to emphasize the fact that we should not treat patients where the treatment is only futile and not utile. So really, the patient selection should be done by the heart team. We should not treat the patient too early, that is to say, intermediate to low risk, we should not treat the patient who is going to die within a couple of weeks, couple of months because of comorbidity. So that's a thing. And to define who is a candidate, who is not a candidate, you should have a look at the patient, because nothing is more different from an elderly than another elderly. You may well be a terrible candidate at 80 and an acceptable one at 90. You should see the patient. The heart team should see the patient. So it's very difficult to catch up. These results are provocative. They are probably somewhat correct, provocative. What we should do is what has been done, to my knowledge, only in Spain. Unpublished data presented here at the ESC last year. In 3 regions, they look at all the patients with severe AS and symptoms, and some underwent medical treatment still, which is not good, because many times it was due to patient decision or patient refusal or family refusal, which is not good, but could be agreed upon. Grossly 30% underwent TAVI, and the rest underwent cardiac surgery. I think we need this prospective assessment with a real complete data recording, taking into account medicine, medical management, conservative, surgery, and TAVI, to see the dynamic of all these. In Germany, there is the German GARI registry, including all patients who underwent intervention, surgery or TAVI, and interestingly, the figure was grossly the same. TAVI represents something like 30% of all interventions for aortic stenosis. Another remark is that this figure is a snapshot, because unfortunately in Europe there is a slight trend, and it's maybe more slight than slight, a trend toward increasing and broadening the indication toward intermediate risk patient, which is not good, which should not be accepted, because we don't know long-term outcome, we don't know all the complications. What we have to do is enroll the patient. In the US, I think partner 2 almost completed enrollment. We'll have the results within a couple of years. In Europe and in the US, your TAVI is enrolling. In the UK, bright people in the UK, they just initiated the UK TAVI trial. When you have a question, try to answer by a good trial, a randomized trial. That is the way to go with this intermediate, but no doubt within 5 years, intermediate will be there, the number will increase. And if I may add, in JAC, I think it's the same issue, or just before, just after, there is another paper by the same group looking at the use of TAVI across Europe. It's going like that, up, up, up. But we are not equal. In Europe, unfortunately, the use of TAVI, the penetration, they call the penetration, that is to say the ratio between TAVI done and the potential candidates for TAVI, no country has reached 100% penetration. That's understandable. But the penetration is much higher in Germany, in Switzerland, in Denmark, than in France. We are just below the average, or in France, Portuguese, or Irish, where it is extremely low. What are the explanations? Of course, it could be the decision of the doctor, but I think the doctors in Portugal, in Ireland, are extremely well trained, and there is not a big gap between their practice or the way they think and the Germans or French or Swiss. The means are different, and they identify 2 main factors. Well, the health of the economy in the given country, and also the reimbursement, the way the prostheses are reimbursed. And in Germany, for example, reimbursement is excellent. In some countries, it's a deal, you have to bargain for one prosthesis, and here, of course, the implant rate is very low. So that's some comments I have.
Well, I think the best thing for you to do is to go off to JAC and read the paper itself and then the commentary by Dr. Vahanian, and you'll see what we're talking about. For Cardial Source World News, I'm Executive Editor Rick McGuire.